We are very lucky to have Doctors Jillian Landeck and Neal Smith from the Belleville Clinic, who will be talking about the impacts of COVID in rural Wisconsin. They are both part of the Rural Health Equity Tract with the Madison residency, and so they'll talk a little bit about that as well. And if you have any questions, please feel free to put them in the chat function in the Webex and we'll go through them at the end. And with that, I will turn it over to Dr. Landeck and Dr. Smith.
Great. Thanks, Tom. And thanks for inviting us to talk about this. It's a topic that's close to both Neal and my hearts. And as Tom mentioned, we're both involved with RET, which is our Rural Health Equity Track. We have no financial disclosures. So I just want to briefly mention our objectives for this talk. So we are going to cover a little bit of the epidemiological data and trends that we've seen in rural Wisconsin during COVID, talk about workforce and capacity related challenges, health system and hospital strain, impacts on medical training, public health challenges, some unique social and economic impacts that we've been seeing in rural areas, and the vaccine rollout. Okay, next slide. So RET, which Neal and I are involved with, I'm the director of RET, and Neal is one of our second year residents. RET is a targeted pathway that we started in 2017 for residents who are interested in rural practice, and the goal being to prepare them to be leaders in rural health. I grew up in a small town up in Sister Bay, Wisconsin, in northeastern Wisconsin. It's a town of about 700 people. I've always loved rural medicine. If not for my husband, who's more of a city guy, I'd probably be working in a very remote location somewhere. But it's really a pleasure to get to work with a group of residents that share my passion for rural, and I love working in Belleville. These residents spend additional time on rural rotations throughout their training. They host workshops on rural health topics, attend rural health conferences, and are involved with community health and advocacy experiences. They also have some specific mentoring that they get during residency. It's a great way to connect with many of our community partners working in rural areas throughout the state, and other rural family docs outside of our system. And we have a lot of fun. This picture is from our recent grad, Kelsey Schmidt's farm, where we hosted a workshop on farm safety a couple years ago out at her farm in Monroe. All right, now we'll turn it over to Neal.
All right. So my name is Neal Smith. I'm a second year resident. And as Jillian was saying, I'm part of the RET program. So our continuity clinic is in Belleville, which straddles the line between Greene County and Dane County. So a lot of our patient population comes from more rural areas. So we have some clinical experience, but unfortunately, a lot of our hospital experiences are in bigger health systems like St. Mary's and UW. So have less experience as far as dealing with rural hospitals during COVID. So if any of you in the audience have more to add on your experiences or have anything to add, please chime in. So I was just going to start out on kind of big picture trends on the COVID pandemic. So you can see on the right the total cases in the United States, as well as the death rate and how it compares to Wisconsin. So interestingly, you can see over to the left the differences in the positivity rate as it compares between Wisconsin and the United States. You can see that there's kind of three peaks. You might be able to tell it's a little bit difficult to compare the three different peaks during the pandemic because of the changes in testing that has taken place and recognition of the signs and symptoms of COVID. So you have to kind of look at the peaks and with a grain of salt. It's not comparing apples to apples, but kind of generally you can see that there are three peaks to the pandemic so far. One in the spring, one in early summer, and then one that happened kind of towards the end of the summer, early fall, and into the winter. And interestingly, when you compare Wisconsin and the United States as a whole, the 7-day positivity rates, you can see that in Wisconsin during the third peak, it peaked a little bit earlier than the rest of the United States, and it peaked a little bit higher. So the peak in Wisconsin was right about in November, end of November, with 18% peak positivity rate, versus in the United States, the peak area was in January at about 13.5% positivity rate for a 7-day average. So so it's kind of interesting. Wisconsin peaked earlier and higher. And if you look at that trend a little bit more closely, there's something interesting to note about it as well. Early in the pandemic, the first two peaks, you can see in the warmer colors, it represents urban centers, and the cooler colors like the greens and blue represent more rural areas. You can see that the driver in the first two peaks were these urban centers, where the case rates were higher among urban populations. But right around the end of the summer, early fall, it started to increase in the more rural areas. And we see that there was a steeper climb in rural areas versus in the urban centers like we had seen earlier in the pandemic. And just to note, rural areas contain about 14% of the population, but around the early fall, they accounted for about 27% of the COVID deaths. So the third wave was really pronounced and harder hitting in the rural communities. This graph shows the cases per 100,000, with the deeper colors, the burgundy is kind of representing higher rates of COVID cases densities, and you can see that they're really concentrated in kind of the rural areas of the upper Midwest. You can see the Dakotas were hard hit, Minnesota, parts of Iowa and Wisconsin. You can see a lot of really dark colors. And, just one thing to note, in North Dakota, I was reading a statistic that 1 in 500 people in the general population in North Dakota died from COVID-19, where in the national average, it was more like 1 in 600. So much higher in rural states, particularly, in the upper Midwest. And you can see in December, the death rate in rural areas was about 50% higher than in urban areas. Also of note, also to keep in mind, is the COVID pandemic didn't proportionally affect all race groups equally. So Hispanic populations were almost twice as likely to contract COVID-19. African Americans were almost twice as likely to be hospitalized with COVID-19. And as you can see here, the rates for American Indian indigenous people was about 1.7. The death rate for COVID-19 was about 1.7 times the rate of the general population. And that's important to keep in mind because rural America is a diverse place. About 1 in 5 rural residents are Black, Indigenous, or persons of color. And the rural areas are getting more and more diverse as time goes on as well. So why was rural America more impacted by the COVID-19 pandemic? I think there's, the jury's still out and there's still a lot of information and pondering to be had. But I think that these kind of encompass a lot of the risk factors that may have led to the more pronounced impact on rural America. And I think a big one is access to healthcare. So there's greater distances between healthcare facilities and people and being able to access care, less specialty care, less hospital beds, less resources in general. The aging population. So, 1 in 5 people living rurally are over the age of 65, where it's more like 17% of the general United States are over the age of 65. So it's an older population, and about 40% of people over the age of 65 have some sort of disability, which predisposes you to have a more severe case of COVID-19. And then also we saw certain occupations were harder hit by the COVID pandemic. Mink farmers in particular, I know, is one thing that kind of sticks out in my mind that was really hard hit by the COVID pandemic. Also, there's higher densities of per population of correctional workers in rural areas. And then also, if you compare certain sectors between urban and non-urban populations in certain sectors, like you can see in the graph on the right, in almost every area, rural occupations were harder hit than their urban counterparts as far as contracting COVID. And then lastly, and maybe most importantly, are the increased rates of chronic disease among rural populations. So the CDC lists 7 risk factors for developing severe cases of COVID-19, including cancer, CKD, COPD, obesity, severe heart disease, sickle cell disease, and type 2 diabetes. And if you look at the graphs on the right, you can see that the rates, when you compare urban and non-urban populations, are higher in almost every category. So higher cholesterol, higher blood pressure, higher rates of asthma, diabetes, COPD, heart disease, and people in urban centers or rural areas are more likely to have chronic 2 or more of these chronic conditions, so predisposing you to more severe forms of COVID. And then on top of that, there's higher rates of smoking and obesity among rural population. So those kind of just to summarize those risk factors, it's decreased access, an aging population, more chronic conditions, and in a lot of sectors of the economy were harder hit during the COVID pandemic. That's kind of a recipe for a disaster. And then on top of it, the healthcare system as a whole was strained, but the hospital capacity in rural communities was already strained, and the COVID pandemic really kind of exacerbated already existing problem. In rural Wisconsin, there's 58 critical access hospitals. So critical access hospitals are kind of an important resource that Wisconsin has, and is actually a pretty well regarded nationally, that provides 24/7 emergency services. They're in areas like 35 miles or more away from other healthcare facilities, but they have one of the specifications for qualifying to be a critical access hospital is you have to have less than 25 beds. So they're relatively small, and they have less resources than say in more urban centers. And about 63% of rural hospitals nationwide are without ICU beds. So having 25 beds is pretty limited, and then on top of it, there's limited amount of ICU beds, ventilators available. If you look at the rates of ICU beds per population, there's about 1 ICU bed per 10,000 people in the rural areas versus about 3 beds per every 10,000 in the rest of the U.S. So stretched pretty thin when the pandemic's kind of raging as far as where to put people that need higher levels of care. And so, like I said earlier, the healthcare system was already pretty strained. 135 rural hospitals had closed since 2010, and 19 closed in 2020. And almost half are operating in the red or with very thin margins. And when you take away revenue and ambulatory care services, those margins get much thinner. So according to this rural hospital vulnerability study, about 12% of hospitals are at risk of closing. So that was prior to the COVID pandemic. So I can only imagine that this has made things worse. And the American Hospital Association quoted about $200 billion in losses from March to June, early in the pandemic. Quite a bit of lost revenue from the healthcare systems. So quite a bit of strain on the healthcare systems to respond to a pandemic. So that's been recognized nationally, and there's a lot of legislation that's been done to address this prior to the pandemic and then also during the pandemic. So Health and Human Services has a pretty good website that kind of outlines the 5 phases of funding rolling out. Each phase has a piece of legislation that allocates money to the healthcare system, and over $62 billion have been awarded so far, and about $1 billion has gone to Wisconsin. The most notable or most recognizable is the CARES Act, and you can see how the money was distributed on the right. And notably, about $11 billion was distributed to rural areas, including critical access hospital, rural health clinics, and community health centers. So it's still yet to be seen whether that amount of money is, sufficient to keep the rural hospitals open and functioning, but it's obviously much needed. So along with that, prior to the pandemic, there was the medical education and physician shortage. So there's projected shortage of about 120,000 docs in the US by 2032. So a lot has been done to try to address the physician shortage prior to the pandemic, with lots of new medical schools being opened, about 29 new medical schools, with 2 new campuses in rural Wisconsin to try to address the shortage. But one of the things to note is it's really difficult to recruit rural physicians if you haven't rotated there as a medical student or as a resident. And so it's kind of a fine balance between making sure that people are being safe with the medical students, that they're allocating proper PPE and keeping medical students safe, but also exposing them to a COVID or to a rural experience, not to COVID, to be able to know whether or not they want to work in a rural area and practice there long term. In the early parts of the pandemic, the AAMC paused all clerkships, in-person clerkships, in rural areas, and recommended restarting rural rotations in August of this year. So that's a big time lapse that medical students hadn't been doing, rotations in more rural areas. And I know personally some of my rural rotations were put on hold due to safety, PPE, kind of this being an uncharted territory as far as a global pandemic. What do you do with medical education? But I think it's a fine balance to being able to train rural physicians, because in the future this likely isn't the only pandemic that we'll face, and it's important to make sure that we're continuing to train rural docs. So that's about all I have for my section.
Well, I'll move into my content then, and we'll have, I think, plenty of time at the end for questions as well. And feel free to enter anything into the chat, and we'll try to address it as we go along. So now I want to briefly talk about the rollout of telehealth during COVID and the impact it's had on rural areas. This has been obviously a kind of a roller coaster for us and our patients to adjust to a new system where so much care is provided through telehealth. And as Neal mentioned, access to care is really one of the greatest disparities impacting rural communities. And telehealth has long been thought of as a solution that we've looked to try to address this gap for access. In 2019, from 2019 to 2020, health centers offering telehealth jumped from 43% to 95%. So, you know, it reflects what we've all seen as far as changes in the work we do, that a huge number of health centers came on board with providing telehealth. However, since COVID, the utilization of telehealth services in rural areas has unfortunately lagged behind urban areas. And since the start of COVID, only 46% of rural households report using telehealth compared to 53% of urban. And one of the main barriers we see is access to high-speed internet. So 1 in 3 rural households across the country had reported either having serious problems with their internet connection or not having a high-speed internet connection at home during COVID. And in Wisconsin, it's an estimated 430,000 people, or 25% of the state's rural population, that lack access to high-speed internet. We think of high-speed internet as being 25 megabytes per second or faster. And so nationally, Wisconsin ranks 30th out of 50 states for our access to high-speed internet. So really not great. At Belleville, we, as a faculty group, did a small project looking at the utilization of video visits at the start of COVID from May to June of 2020, and found that only 29% of our telemedicine visits were conducted by video, with the majority of telemedicine being done by phone. And I think this is still the case from my experience. And the concerns that patients cited, internet concerns were one of the top 3 barriers to doing a video visit. So there's still not a lot of pooled data about telehealth in rural areas, but this graph shows the percentage of weekly telehealth visits at HRSA-funded health centers, comparing urban on the left to rural on the right from June to November of 2020. And as you can see, there's a substantially lower number of visits done by telehealth in rural versus urban areas, despite the number of cases of COVID being higher in urban areas compared to rural. And high-speed internet, often, if it is available in rural areas, it's often more costly. So that's a significant issue, and less reliable. So obviously, beyond just impacting access to telehealth, high-speed internet access impacts access to education, work from home, social isolation. So has just huge impacts for anyone living in a rural area who lacks high-speed internet. So for good reason, there's now increasing pressure to consider broadband access as part of our basic infrastructure in this country. It's kind of similar to how we once looked at telephone service. So back as part of the New Deal in 1934, the FCC was created to subsidize phone service in rural areas and for low-income households. So flash forward to 2020, the federal government now just recently passed what's called the Rural Digital Opportunity Fund. And it's an effort that's going to provide $20 billion over 10 years to try to address this and ensure availability of high-speed internet and subsidize the cost to try to make the cost of internet competitive to urban areas. Unfortunately, 20 billion is a lot of money, but FCC actually reports that it may take up to $80 billion to actually meet this gap. In Wisconsin, in January, Governor Evers also announced he wants $200 million in the next state budget to expand broadband. That's on top of $54 million from the previous budget. So So good that we're seeing more attention to this issue, but likely more pressure will be needed to fully bridge the gap. I'm going to talk about some other social impacts of COVID that I think are important to be aware of. So unemployment. So this one's kind of interesting because overall we know income and wealth across the country is lower when you compare rural to urban. But this graph shows that unemployment rates during COVID have actually been lower in rural areas compared to urban. So you can see pre-COVID, the blue line is rural, our unemployment rate was higher, and then come COVID, oops, sorry. Sorry. Rural areas have now dropped lower than metro areas in terms of unemployment. So as you can expect, that reflects the industries that have been hit hardest. So retail, dining, entertainment. But it's important to kind of call out some areas that are really still struggling in rural Wisconsin. So in 2020, Wisconsin led the nation by far in farm bankruptcies. So we had 69 farm bankruptcies, which was more than double the state with the second most, which was Kansas. Specifically, we lost 818 dairy farms in the state, which was mostly not due to bankruptcies, but due to farms selling off their herds or getting out of the industry. So a lot of struggles still going on in agriculture. Just want to briefly touch on the disparities in the lack of access to childcare. And this is not to mention the impact of virtual schooling, which is still being measured and compared to urban data. But pre-COVID in 2017, 59% of rural census tracts were considered childcare deserts. A childcare desert is defined as an area that has no childcare providers or has more than 3 children for every available slot in childcare. And we know that in rural areas, households tend to rely more on home-based childcare. It's been really costly for these smaller centers to adhere to strict cleaning regulations, or they often have staff that have had to stay home with their own children due to virtual schooling needs. So we're seeing, I know it anecdotally in my practice, a lot of families really severely impacted. And I think that the data will show that down the road. Food insecurity, also a major issue for rural Wisconsin. There's a recent WP article that interviewed several regional food pantries about this. The rates of food insecurity pre-COVID were higher compared to urban areas, and we've seen some worsening of that since COVID. 63% of counties in the US are rural, and of those counties, 80% had the highest rates of overall food insecurity. Prices on groceries in rural areas are higher. They're on average 4.2% higher than they are in urban areas. And during the pandemic, prices across the board on groceries have risen 2.6%. So you can imagine that disproportionate impact on rural areas. And we're seeing now that 20% of rural households since the pandemic live in food deserts. I also want to call out some staggering rates of intimate partner violence that are seen in rural areas. And unfortunately, this isn't a new problem either. And due to the way that survey data is collected nationally from victims of sexual and physical assault to protect their identity, we often don't have a lot of clear data to compare rural versus urban. But we do have some data related to emergency department visits for intimate partner violence. And this is old data here in this graph, but as you can see from the red bars, in most of the country, the rural visits to EDs for intimate partner violence are much, much higher than in urban areas. But interestingly, the data we have suggests that in the Midwest, that we actually do better than the rest of the country. But I think regardless, we know that economic pressure, physical isolation, limited access to transportation are all contributors to the rise in violence that we see in households. There was a study in radiology this year that looked at visits to the ED that had X-ray evidence of intimate partner violence and found overall a 1.8-fold increase in these cases since COVID. So pretty scary. There was a survey from the Robert Wood Johnson Foundation and Harvard that came out in October of last year that interviewed households across the country about the impacts of COVID and had some interesting findings comparing rural to urban. that I thought I'd mention. So here we see in this pie chart that 24% of individuals reported someone in their household has been unable to get medical care for a serious problem when they needed it during COVID, either because they were unable to find an appointment or couldn't afford it. And 56% of those individuals reported negative health consequences as a result. And importantly, this survey found that 85% of Black or Latino rural households reported facing serious financial problems during COVID, compared to only 36% of white rural households. Pretty huge difference there. I want to draw attention to really the extraordinary efforts of public health departments during COVID, and our small rural health departments have really been especially strained during this time. They often have, very few staff compared to urban health departments, and their staff often have less kind of formal public health training and little to no support from epidemiologists and statisticians. So they are covering a lot of work during this time. Last fall, Neal and I, we had a RET seminar on this topic and talked to our local Greene County Public Health Department just about all the challenges that they're facing with their very small staff, trying to concurrently manage contact tracing, investigating outbreaks, educating the public, doing outreach, testing, and now vaccination efforts. It's just really a huge amount of work on a small number of staff. I was saddened to discover, doing some research for this talk, that Wisconsin ranks very near the bottom for public health funding nationally. We're ranked number 48 out of 50 for the amount of state and federal dollars spent on public health. I want to shift to talking about the vaccine now, something on everyone's minds. So unfortunately, vaccine hesitancy is a very real issue. I'm finding in my clinic visits that myths about the vaccine hesitancy are just rampant, and something I'm spending a lot of time talking to patients about. There was a really interesting survey from the Kaiser Family Foundation that looked at vaccine hesitancy in rural America. And they found on the bottom here, you can see for rural residents that only 31% that said that they would definitely get the vaccine if offered. And 35%, if you combine the two green colors there, said they would definitely or probably not get it, as compared to suburban and urban in the lines above. And as we know from the numbers that we've gone over, that our rural patients are certainly no less likely to know someone who's tested positive or died from COVID, but they seem to be less worried than their urban counterparts that someone in their family will get sick from COVID. And they're much more likely to say that the pandemic is exaggerated. So additionally, they found that 62% of those in this survey reported that they see getting the vaccine as a personal choice, and only 32% see it as part of their responsibility to protect the health of their community. And more than any other demographic group in the survey, 49% of white Republican men report they don't plan to get the vaccine. So although the findings did report that rural counties, are more politically conservative, as we know, that the vaccine hesitancy and lack of worry that is reported really extends beyond partisanship. And then arise concerns regarding vaccine distribution in rural areas. So as we know, the federal government decided, in addition to clinics and public health departments, to distribute a large amount of vaccine through the Federal Pharmacy Partnership. And initially, the number of pharmacies was limited, and this raised concerns because we know that 10 rural counties in Wisconsin don't have a CVS or Walgreens, and Florence County, which is up in the far northeastern corner of the state, has no pharmacy at all. Since the partnership has expanded to include other pharmacies, hometown pharmacies, which we have a lot of in our area, Walmart, Hy-Vee, and others, but it still concentrates vaccine availability to urban areas. I kind of told some patients if they're having trouble finding a vaccine, that you may consider calling some of the rural public health departments, because we've actually seen Greene County has done pretty well with distributing the vaccine, and some of these rural departments have more vaccine available than urban. And this map shows the amount of vaccine that's currently been given out in rural county across the state as of Sunday, April 4th, just this past Sunday. You can see the darker counties are where they've distributed more vaccine, and they're primarily concentrated around Madison, Milwaukee, La Crosse, with the exception of a couple counties where the average age is quite old, Bayfield and Door County. I had to check a little bit because my hometown, Sister Bay, held the record for many years. Sorry, I don't know why it's skipping. Sister Bay was the town with the oldest mean age in all of Wisconsin, which I think was somewhere around like 62. So I thought I was probably one of, 10 families with small children growing up there. Cold storage is quite costly and difficult for some departments to set up, not to mention transportation for patients to get to vaccine sites and staff to administer the shots. In an attempt to address this, the state deployed 9 vaccine teams, mobile vaccine teams that are staffed by the National Guard. There's $86 million in additional funding that's been approved for 2021 to help with vaccination efforts. This map further shows the disparities around vaccine access in rural areas, with the red showing counties with no pharmacy and the yellow are counties with 1 pharmacy. So obviously concentrated kind of more in the heartland here. And I think if we're going to try to overcome some of these distribution challenges and hesitancy issues, we're going to need some really targeted efforts to both educate patients about the vaccine and dispel myths, but support public health departments even more. I know UW is working on their vaccine rollout very actively. I think we really need to prioritize making the vaccine available in our rural clinics and think innovatively about other locations that people can get vaccinated, such as through vaccination events, churches, community centers, things like that, especially for our persons of color living in these areas. The single-dose Johnson & Johnson vaccine could be a really good option for individuals who are vaccine hesitant, to kind of at the time of a visit, be able to offer that to somebody, or for folks who have transportation concerns and maybe aren't going to be able to make it back for their second dose. So just to summarize, and then we can move into some discussion and hopefully answering questions. There's not a lot of data available regarding the impacts of COVID in rural areas, but from what we do know and what we can project, I think we're going to see a lot of worsening of the pre-existing healthcare disparities that we know. For Black, Indigenous, and persons of color, they're at even greater risk if they live in rural areas of facing the brunt of this impact. And then there's a need for this targeted support for rural hospitals, for public health, for telehealth and broadband expansion. And we need to continue to support rural medical education. We're seeing some unique social implications of COVID that we need to be mindful of when we're seeing our patients and thinking about social determinants of health. And then obviously the need to improve vaccine access and address vaccine hesitancy. Oh, and just some brief acknowledgements. So Val Gilchrist helped with some of the content for this presentation, Lou Sanner and our RET steering committee for all of their ongoing support. And then from a similar seminar that we held in the fall, Bridget Cracker from Greene County Public Health, Tim Size, John Ike, Charlie Pierce from the Dodgeville Upland Hills group were all really instrumental in making that happen. So great. I'll just stop sharing my screen and can open it up to questions. Let's see, I see a couple in the chat here. So maybe we can start with that. Looks like Is the vaccine distribution per county based on population? Are they taking into consideration lower income counties taking priority? Yeah, so there may be other people on this call that want to chime in. I wish I had a better understanding of some of how the vaccine distribution has taken place and how counties have been selected to receive more or less of the vaccine. So to be honest, I feel a little uninformed, and I think a lot of us and a lot of the public do, as far as understanding why vaccine is more available in certain places than others. And then there was a question about putting, I think from Andrea as well, about how can we put pressure on increased funding for public health in Wisconsin. Advocacy. I mean, I think getting involved. I know Dr. Day is around the corner here. I think calling legislators, all of those things really do matter. But I'll open it up to other ideas. Neal, on both of these questions, Neal or others, appreciate any other thoughts out there.
Well, I can take a stab at maybe the first one, but I see, and I don't know everybody on the call. It's nice to sort of see a bunch of names, but great presentation, Neal and Jillian. You really covered a lot of ground there about the challenges for our rural populations with COVID and the pandemic more broadly. I mean, I think part of the reason you don't feel informed is none of us feel super informed. There hasn't been as much transparency, I think, around how the vaccine is being distributed as maybe we'd all like. And John Tempty, if he is on the call, I see his name listed. He might have more background on this than I do. But I can tell you that, I mean, in general, my understanding is that the state was trying to do it on a sort of a per capita basis based on the population in each county. But then operationally, it gets challenging because of the vaccine storage requirements and who's actually certified as vaccinators. And there aren't as many of those sites available in the rural setting to this point. The J&J is obviously really important with that. But I mean, the state has certainly said as a goal and a vision that they want to be equitable in their vaccine distribution, and they're taking something called the Social Vulnerability Index into account, which was developed by the CDC to guide those distribution decisions. So John may want to comment on that more, but just at the UW Health level, I can also tell you in the service chiefs, I don't think I see any of the service chiefs or Sandy Kamnitz online, but UW Health is looking at and has applied for several of our primary care clinics to become vaccinator sites. And I think the goal is to have all of them certified, in the next month or so. And then on top of that, there'll still be the vaccine supply issue. So, and making sure we can handle it with the right education and training for the staff, and that patients can get the vaccine in a way where they expect to. So in other words, if we don't want patients coming in for vaccine if there's no supply yet.
Yeah, Jeff, I'll just comment real quick that it's a really complicated process. I think there are something like 12 or 1,300 vaccinators registered with the state. They each have to turn in a weekly a request. Little to my knowledge, but learned, maybe 2-3 weeks ago that there was a contract with the data scientists on the UW campus to develop an algorithm to look into the requests coming in, the population, the social vulnerability index, and all these things on a weekly basis, try and spit out the appropriate amount. But then you have to kind of keep in mind that things change. And a group may request, 1,000 doses and are only able to dispense 30 because of lack of interest or people showing up. So it's really, really complicated. That being said, Wisconsin is leading the nation, I think, in terms of getting out doses that we receive. So it's both good and bad.
Thanks for that, Jeff and John. Really appreciate your expertise in this area. And yeah, as John mentioned, I don't think it's all doom and gloom. I think Wisconsin's actually doing quite well overall in our efforts. There's a comment here, a question from Shelley Shaw. Would be great to hear thoughts on the physician's role in shaping narrative around COVID in rural settings. Mentioned vaccine hesitancy, mask wearing is also lower in rural settings. Absolutely. Yeah, and certainly we've all seen now with changes from the mask mandate and all along we've seen, I think, especially for those of us that practice in places like Belleville, mask wearing, people being resistant to that, and even more so now with changes in the mandates. So yeah, a big concern and something I think we need to continue to watch how changes in mask wearing practices impact these areas. Physicians' role in shaping the narrative around COVID in rural settings. Yeah, I think this is obviously important, not only just in the conversations we have with our individual patients and but in terms of advocacy and the conversations that we're having more broadly. And Jeff and John are great examples of helping to shape that narrative. I don't know, Neal, if you have other thoughts around that, or Shelley, if you had anything else you wanted to share, any suggestions?
This is Tom Hunt. I'll just add too, I think I sort of see it as almost two things. Like, you need the big public health measures to promote some of the COVID safety measures, but I also think the individual anecdotes coming from doctors are particularly powerful sometimes. Although I think many of us just hit roadblocks as well, as sometimes patients come in with, my family member who's a nurse told me this, and this is what I'm going to believe. And so sometimes the messaging from the healthcare professional doesn't always overcome messaging heard from other people, regardless of how credible. So it is a particular challenge, but I think the balance of both public health messaging as well as individual anecdotes from physicians or other health professionals is sort of what we have and sometimes works.
Yeah, I think from the Kaiser Family Foundation report, some of their outcomes were making recommendations to, how are we going to penetrate this sort of white Republican male demographic that's so vaccine resistant, and talking about, trying to use specific media outlets that they use more of, things like Fox News. And I thought it was kind of interesting, some of the recommendations they had there, but yeah, very challenging. There's another question here from Edmund Ramley about any insights on what disparities, inequities are likely to endure most longest after we emerge from the pandemic, in light of your research and preparation for this. Yeah.
One of the things that I was thinking about, as far as like after the pandemic, what's an area that that needs to be an area of focus as far as improving rural health is improving emergency medicine services and specialty services in rural areas. I think that we've seen that obstetric services in rural areas have gone down. Emergency services are really important and vital in rural areas, and they're particularly vulnerable to pandemics where there's limited people to come in behind if a whole group of people are getting sick. So I think training EMS providers and things like that. So the healthcare workforce is something that I think is one area that's going to endure for a long time after the pandemic and needs to be addressed long term. And then the other part is what Jillian talked about, was the access to broadband. I think that's one of the great equalizers, is the availability to to have access to healthcare in rural area. You can have access to specialty care if you have broadband access. So I think that'll be a fight that needs to be had after the pandemic is over.
Yeah, I mean, I agree, Neal. I think, and so many of the chronic disease disparities have existed for such a long time that I imagine those will persist, for quite a while and be, unfortunately worse post pandemic. I'm hopeful about telehealth. I mean, I think that for a lot of patients that I've seen that, maybe have struggled to see a certain specialist, they now have been able to because of access to telehealth. And if we can really, expand and improve high-speed internet access, I think it could go a long way beyond, just access to telehealth, but also affecting other sectors as well. So let's see, there's several questions I want to make sure I am able to bring to the group while we still have time. Andrea learned that white evangelical churches are very opposed to vaccination. Yeah, it kind of echoes what I think we learned as well. Paul Hunter, what would the role be for small group listening sessions with vaccine hesitant people facilitated by community health workers trained by public health professionals? Okay, Paul signed off and now he's back. So I love the idea, Paul. I think it would be really enlightening to do some more listening sessions with vaccine hesitant groups and explore this more. I don't know if you wanted to add any other thoughts to that.
The reason I ask is that there's something similar to that to a certain degree that is happening in Milwaukee. Parts of it, they haven't all been connected together, that I've been involved with a bit. And just curious if anybody has thought about whether that's a good idea or not, and whether putting the parts of that together to actually give it a try might work.
We've been doing some listening sessions with community health workers in Dane County. But it's been really based on kind of community by community request, right? So I know that Morgan White is engaged in some with the Harambe Village, and then we're also working with Sun Prairie Neighborhood Navigators on hosting some conversations. So it hasn't been real strategic at this point, but would be great to be doing that in rural setting as well. So something we could think about following up on.
Yeah, I think it's a fantastic idea. I'd love to talk more, maybe offline. And if there are others that are interested, please reach out. I think that could potentially really go somewhere and be really informative. Andrea also asked, I think this was just sent to me, have ICUs in rural areas been able to manage the number of COVID patients and patients with other conditions that need ICU care? I think, it depends, but I think it's really been a struggle, especially back in November, December during that spike. My sister is an ER nurse in Door County and had several cases that it was just shocking, somebody they needed to transfer out with a STEMI to get to a cath lab, and none of their the hospitals they would normally transfer to in the area being able to take the patient, and having to transfer that particular patient all the way to Watertown, and just similar stories that I've heard where normal ways of getting patients care had kind of just broken down. And I was excited to hear that it sounds like they're dismantling the field hospital near Milwaukee. They're not finding that there's a need for that. So, but yeah, I mean, I think as we saw in our Madison area hospitals, ICU beds very tight and across the state. So with rural hospitals, critical access hospitals not being able to find ICU beds when needing them. Are you thinking about planning for and treating long-term symptoms of COVID in rural communities? Yeah, something we're definitely seeing more and more of, ongoing symptoms related to COVID, and still so much to learn in this area. I don't know that we have I'd be interested to hear if folks in the department are focusing on this more. I've just tried to do as much as I can to learn about some of these long-term symptoms and how to address them with my patients. But gosh, I wish we had more effective treatments out there. It's really been an unclear territory.
It's definitely a talking point when talking about COVID safety measures and vaccines and reasons to do it.
Absolutely. Couple other comments I want to try to go through here. I really appreciate everybody being so active in the chat. There are some focus group tested messages now on the messaging best received for vaccine hesitant groups. It's clear people want education, not indoctrination, and they're most likely to listen to their doctors. Great. There's a link there. Look forward to checking that out. Thanks, Jeff. We heard many of the same issues in our work with the state on rural health equity from Shelley with a link there. Thank you. And then population health is about to start urban vaccine educator work targeted to communities of color. Great. So wanting to connect about that. Wonderful. Yeah, I mean, I think it's something, a population that we really need to do more outreach to and understanding how to best serve our communities of color in rural areas. It has not been, I think at the Belleville Clinic, we've unfortunately in the past sort of heard some resistance to even receiving care at our clinic, and issues around trust and lack of feeling like there's available interpreters. And so, I mean, I think pre-COVID there are efforts that we need to be making, and everything has probably just been exacerbated because of COVID. But yeah.
I think we're just at about time, but I did just want to thank both of you, Jillian and Neal, again for highlighting the impact of COVID in rural communities. And I think as we've seen from our discussion, just remembering to keep rural communities, especially in our state, in mind, because they truly are impacted. And I think there's still a lot of work that we can do and still have time to do. And it looks like some potentially good collaboration efforts in the future to reach some of the needs in rural communities. So thank you very much, and thank you everyone for attending the forum. There will be several more forums in the next several months about COVID and other topics, so please keep an eye out for those. Thanks everyone, have a good day.
Thanks so much.